malignancies. I think we've made great strides. I think Jesse and his efforts have contributed to the insight and knowledge for breast cancer. And I got to tell you, if anybody's tried to jump into the race of breast cancer, it's one of the fastest changing worlds of treatment. I can tell you that when I went to start my practice in Watertown back in the 80s, I was taken to the ethics committee because I had offered a woman a lumpectomy and an axillary dissection, when everybody knew that modified radical mastectomy was the only way to treat breast cancer, and that I was considered a bit of a wild man because I was doing things outside of the norm. Well, holy crap, if they'd see the stuff we're doing today, all of you would be at the ethics committee having to explain the procedures of what we're doing, but that just speaks to the rapid change in breast cancer treatment, and we're blessed to have somebody so insightful and so compassionate to deal with not only the knowledge that you need to have and possess to be a breast cancer surgeon, but be able to take the time and show the compassion. So it is my pleasure therefore, to introduce to you Dr. Dirksen, who's going to speak about management of the axilla in breast cancer patients. Please join me in welcoming Dr. Jesse Dirksen.
I told Dr. Timmerman to keep that short. Thank you, Gary. That was very, very kind. Thanks for being here today. Very kind introduction. So my ED thoracotomy story, we were talking about that this morning. I did 2 trauma rotations at Shock Trauma in Baltimore, Maryland. And my first night there, we had 39 traumas. And these are legit traumas, just like Cook County. And we had 2 ED thoracotomies my first night, and we saved them both. And I thought that's the way it should be. Mm-hmm. And since then I'm 0 for 7. So, yeah, percentages are playing out. Today, we're going to talk about management of the axilla in breast cancer patients. Can everybody hear me okay? Perfect. Dr. Timmerman is correct. Breast cancer treatment, breast cancer strategies are constantly changing, constantly evolving. Literally every month something new is coming out about this. I wanted to talk about the axilla because this has changed significantly in the past few years. Not a very sexy discussion. I'll try and keep it as interesting as possible, so please bear with me. No financial disclosures. So we're going to talk about the evolution of lymph node surgery. We're going to talk about current studies. And then we're going to briefly talk about lymphedema and what's the latest there. Always got to have a quick review of anatomy. When we talk about axillary lymph nodes, we talk about 3 levels. Every medical student will know this is in all relation to the pec minor muscle. So your level 1 lymph nodes are going to be lateral to the muscle. Level 2 is deep. Level 3 is medial. There's a lot going on in the axilla. Obviously, axillary vein and artery, brachial plexus, your long thoracic nerve, your thoracodorsal, you've got your intercostal brachial nerves. A lot going on. So you got to know your anatomy. I'm a big history guy. I always like to remember where we came from, how we got here. Dr. Halstead, or excuse me, was one of the professors at Johns Hopkins. He was the first one in the United States to perform a radical mastectomy. This was in 1882, which is 135 years ago. The radical mastectomy, it truly was radical. You remove the breast, you remove pec major and pec minor, and you remove all 3 levels of lymph nodes. As you can imagine, this did not come without complications. Biggest concerns was lymphedema, chronic pain, nerve injury, and it was very disfiguring. And I still see some of these patients in my office once in a while, and just to see the ribs right underneath the skin kind of takes your breath away a little bit. A lot of clinical studies and trials, especially the NSABP before, it showed that a radical mastectomy did not provide any benefit over a modified radical. Basically, a modified radical preserves the pec major muscle and minor muscle, And also the level 3 lymph nodes are not removed. By not removing the level 3 lymph nodes, that significantly decreased the rates of lymphedema. Then push the boundary even further, and some brilliant people had the idea, do we need to take all the lymph nodes? And this kind of started out in California in the United States. They had been doing this in Europe prior. Dr. Giuliano, if there's a Mount Rushmore of breast surgeons, he definitely would be on it. He's pioneered a lot of our current practice guidelines. And in the early 90s, he helped pioneer our Sentinel lymph node biopsy technique. And these studies were confirmed by the NSAPB and a Z10 trial. And as we all know with this technique, a lot of times dual tracers are used. There's a technetium and then a blue dye. Technetium is a radioisotope, and currently at Stanford we're using what's called Lymphoseek, which has a very high specificity for lymph node tissue. You can also get lymphoscintigograms, where after the injection you can see where that tracer is uptaken. I actually quit doing these. I didn't find them particularly helpful, and also it kind of takes time and it's an added expense, and patients have to wait in nuke med to get these images every 15 to 30 minutes. So I have been skipping these lymphoscintigograms. With blue dye, there's two types of blue dye. There's methylene blue and lymphozurin. Lymphozurin is a little bit more expensive. Sometimes it can be difficult to get here at Stanford. It does seem to have a better uptake than methylene blue. It's always good to know rare complications. With methylene blue, there's a rare chance of skin and fat necrosis, and then lymphozurin, rare chance of anaphylaxis. Personally, I do not use blue dye. I've had very good success with just the Lymphoseek. So in most situations, I am not injecting blue dye. There's two ways to inject it, though, if you use it. A lot of surgeons will inject it right under the nipple areolar complex. There's a rich lymphatic system there called Saphys plexus. It has a great uptake to the axilla. And then some surgeons still inject around the tumor. Both techniques are just fine. Gotta wonder about pregnant patients. Surprisingly, technetium is safe to use. Blue dyes are contraindicated. So I take care of maybe 1 or 2 pregnant breast cancer patients a year. It is okay to do sentinel lymph node biopsies in them and use the technetium, no blue dye. I thought this was a really cool picture. You can't read this, but this cute little girl's shirt says, "You think you're tough? I went through chemo with my mom." So, it's pretty cool. And what's really cool, Brittany and I, we see these patients back in the office, and every once in a while they take their babies with them. It's kind of neat to see the babies. Traditionally, we've always done frozen sections. Obviously, if the frozen section was negative, we did no further lymph node surgery. If it was positive, we moved on to an axillary lymph node dissection. I'll kind of explain how that's changed recently. Also of note, there's been a great variability in how many lymph nodes to remove. I've looked at several studies. Usually the mean number of sentinel lymph nodes removed will usually fall between 2 and 3. This study from 2008, their mean number was 2.9. And this study also said, you know, within the first 5 lymph nodes, you're going to have a 99% success rate of finding any malignancy. So typically on a sentinel node, if you're getting beyond 5 lymph nodes, I personally would stop. I don't see the benefit of taking out 7 or 8 lymph nodes with a sentinel lymph node biopsy. So what's new? We all know Z11. I guess this trial isn't so new after all. It's been out about 6 or 7 years. Quick review, 800 patients, smaller than a T3 tumor, so less than 5 centimeters. These patients had to be clinically node negative. They underwent a lumpectomy and a sentinel lymph node biopsy, and then they were randomized. So women who had 1 or 2 positive lymph nodes, so less than 3, they were randomized to an axillary lymph node dissection or no further surgery. Follow-up was over 6 years. And they looked at local regional occurrence, disease-free survival, and overall survival. Most of these patients got some type of systemic therapy. They either got chemo or anti-hormonal therapy. And then in terms of recurrence, especially that regional recurrence was very low and very similar between the two groups. And disease-free survival and overall survival was essentially the same between the two groups. Also of note, I thought this was real important. So the women who are randomized to axillary lymph node dissections, 27% of them had further lymph nodes with cancer. What that means is over 2/3 of women had an axillary node dissection with basically no added benefit. So I thought that was pretty interesting. So what does this mean for us? And this again right now is for lumpectomy patients. I personally don't do any more intraoperative frozen sections in a T1, T2 patient with clinically node-negative disease. So I'll do the sentinel lymph node biopsy, but I will no longer send them for frozen if they're clinically negative during surgery. Let's say you get that pathology report back a few days later. Even if 1 or 2 lymph nodes have cancer, you do not need to go back. Those patients are likely going to get chemotherapy. They're likely going to get endocrine therapy if they're hormone positive. Z11 showed us that that's safe. Big question is, can this be applied to mastectomy patients? And I think the answer lies within radiation. So what's the difference between a lumpectomy patient and a mastectomy patient? Lumpectomy patient likely is going to get radiation. And with radiation, a lot of times not only are they hitting the breast, but their tangents tend to go up high, and they also end up hitting the axilla. With mastectomy patients, a lot of patients don't get radiation. Now the NCCN Guidelines say the reasons to do post-mastectomy radiation are those reasons, but more importantly, you have to have 4 or more lymph nodes involved. Now there are literally dozens of clinical trials right now looking at women who have 1 to 3 lymph nodes involved, and should we radiate them or not? I would say at Sanford, our radiation oncologists tend to be very aggressive. I would say women with 1 to 3 lymph nodes likely will get post-mastectomy radiation. And like I said, these patients also are going to be getting other treatment. I think Dr. Crew would agree with me that a lot of these patients are getting radiation, which makes her job more difficult. Dr. Cody, he's a surgical oncologist at Memorial Sloan Kettering. He wrote a really nice editorial in the Annals of Surgical Oncology recently discussing this. And what he basically said is this is a multivariate decision that has to be made. There's no clear guidelines right now. And he also did say it's very clear indeed that the role of axillary lymph node dissection will continue to decline. And I think this is very important for the residents. There's fewer axillary node dissections being done. It is still a very important procedure to know how to do, because likely you're going to be required to do this at some time in your practice, even with melanoma. So try to scrub as many axe dissections as you can while you're here. A lot of anatomy going on in the axilla. And once you do them repeatedly, it's actually a pretty straightforward procedure. Kind of a funny story about Dr. Cody. 2 things I remember about him. 1, he's very tall. He's about 6'7", which I love, so the table height was always good. And then his claim to fame is he never uses Bovie. He uses pure scalpel for his mastectomies. So his mastectomies take about 10 minutes, but then he leaves the room and tells you to dry it up. And then you're in there for about another 30 minutes trying to cauterize all the vessels. So another institution looked at this, guys here in Pennsylvania, and they kind of looked at Z11, or they looked at their practice tendencies pre and post C11, and in their own numbers, they showed that the rates of axillary lymph node dissections have decreased after Z11 in both lumpectomy and mastectomy patients. So, unfortunately, I think a lot of this falls on the surgeon. I'm starting to look at patients differently. Let's say I'm doing a mastectomy and I do a sentinel lymph node biopsy. And let's say that patient's 70 years old, she has a low-grade tumor. We send off lymph nodes, let's say I send off 3 sentinel nodes. Only the very first lymph node has cancer, the other 2 are clean. She's hormone positive. I likely will not do an axe dissection with her anymore. Flip side, if I have a 32-year-old female, high-grade tumor, big tumor, send off 3 lymph nodes, 2 or 3 come back positive, she's triple negative, HER2 positive, I probably still will do an axial dissection. And a lot of that intra-op decision-making falls on the surgeon, and unfortunately right now, there's no black and white, there's a lot of gray. Another thing that has changed recently is clinical staging. Stating the obvious, we always get mammograms of the breast, we always get ultrasounds of the breast, but we've been getting a lot of axillary ultrasounds lately, preoperatively, and what the radiologist is looking for is any abnormal appearing lymph nodes. If there is any abnormal appearing lymph nodes, the breast radiologist will do a core needle biopsy. And what we mean by that is not only are they looking for enlarged lymph nodes, but you look at some characteristics. So in the center of a lymph node is a fatty hilum surrounded by the cortex. The radiologist is mostly looking at, is that cortex thickened? And if it is, sometimes it will press on the fatty hilum and it will compress that. So if they see a thickened cortex and the fatty hilum being replaced, that is concerning, even if the lymph node is a normal size. And they will end up doing a core needle biopsy of that. If this core needle biopsy comes back positive, this will likely lead to neoadjuvant chemotherapy. Now, neoadjuvant chemotherapy just means doing chemo prior to surgery. There's 4 potential benefits of neoadjuvant chemo. 1, you're doing a systemic therapy first. 2, we can monitor the response of therapy while we're giving that. And this is really beneficial in women with palpable masses. So let's say they get 3 or 4 cycles of chemo. That mass is shrinking on exam, great, we have them on the right stuff, we keep going. Also, there's a lot of women who have a large, bulky tumor. We can shrink that down with chemo. It might make them amenable to lumpectomy. And then also, if we do the surgery after chemo and they have a complete pathological response, that is very, very prognostic for the patient. Typically, those patients will do better than those who have any residual disease. What about sentinel lymph node biopsy neoadjuvant chemo patients with a biopsy-proven lymph node? And what I mean by that is, let's say the scenario is a woman has an X-ray ultrasound, they do a biopsy, that lymph node comes back positive. They have chemo, now it's time for surgery. Typically the answer has always been, just do a complete axillary dissection. But when we first started doing that, we noticed that about 1/3 or more of these patients had a complete pathological response, which means we looked at all 15 lymph nodes and they were all clean. And we're like, great, did we really need to do that? So American College of Surgeon Oncology Group, Z1071, is kind of another landmark study. Dr. Bowie from Mayo presented this in 2013. They looked at 600 and some patients after chemo with node biopsy proven disease. And they looked at the results. Their path CR was around 41%. But the biggest factor that they wanted to look at this was their false negative rate. They wanted a false negative rate less than 10%. During the study, it was 12.6. And what I mean by that is, let's say you do a sentinel node, Frozen's come back negative, great, do not do the axillary section. 3 days later, you get the path report back, and the pathologist says, oh, by the way, we did see some cancer in those notes. It's not a very fun phone call for the patient, and I know a lot of people in this room have had to make that phone call. Well, what can we do to decrease that? And they've looked at that since the study. 2 things they recommend, and there's a third I recommend. They do recommend using dual agents, so you're using both technetium and blue dye. So in these patients, I will use a blue dye, and I inject it in that sapes plexus behind the nipple. And then they also recommend removing at least 3 lymph nodes, and that greatly decreased the pulse negative rate. Another thing that we're doing here at Sanford and other institutions is I have them clip the lymph node at the time of their corneal biopsy. When I do a sentinel lymph node biopsy, I now x-ray those 3 or more lymph nodes I take out. If the clip's in there, great. We know we have the node that they biopsied. And if the pathologist says that node is clean, other nodes are clean, do not have to do an X dissection. So what does this mean for us? So yeah, there's likely a role for sentinel lymph node biopsy after neo-adjuvant patients. As long as you use a dual tracer, take at least 3 nodes and clip the node. And also I think it's very important to be selective in these patients. Obviously patients get a lot of imaging with their workup, and I have them repeat imaging after their neoadjuvant chemotherapy. And a lot of times we'll do an MRI after treatment, and if there's no adenopathy on MRI, that's more reassuring to try to do the sentinel node technique. Now on the flip side, if you have this patient after chemo, they're node positive on biopsy, you send the Frozens and they do come back positive, then absolutely you got to do an X dissection. Another big question mark, or question that hasn't been answered yet, is what do you do in node-negative patients who have neoadjuvant chemo? And what's happening with these patients is the radiation oncologist likes to know, are these patients truly node-negative or not? Because that will affect if they recommend radiation after mastectomy. So I don't know how I feel about this, but lately my partners and I, when we put porticast in for neoadjuvant chemo, a lot of times we'll do a sentinel lymph node biopsy at the same time. And that way we can get a definitive answer, are they truly node-negative or not? Would they require radiation after surgery? There was an article recently in the Journal of American College of Surgeons kind of discussing this and talking about the surgical management of patients with neoadjuvant chemotherapy. And they looked at 2 big neoadjuvant trials, the Cancer and Leukemia Group B, HER2 positive trial, and the triple negative trial. And basically what they said, everybody's all over the board. There's no consensus. There's a lot of variability in what we're doing right now. And in the preoperative imaging of the axilla, that needs to be biopsied. Some institutions are doing FNAs, some are doing corneal biopsies, and some are doing sentinel lymph node biopsies. In patients after neoadjuvant chemotherapy, if they have N0 disease, that's been very concordant. Those patients get sentinel lymph node biopsies. In node-positive disease, that's been widely variable too. Some do a sentinel node, some jump right to an X dissection, and surprisingly with this study, some surgeons didn't know. So, what's it say? Basically, we have no idea. And this has kind of really muddied the picture for us surgeons. Neoadjuvant chemo, we always did surgery, did chemo, did radiation, did pills. Now that order's getting mixed up. Again, like I just said, there's no stringent guidelines at this time. My personal take this for what it is. I would recommend doing an axillary ultrasound on any patient with invasive breast cancer. If that ultrasound is abnormal, either yourself or the radiologist do a corneal biopsy and clip that node. You want to monitor the response of neoadjuvant chemo while you give it, and then get some imaging afterwards. I think it's appropriate to do a sentinel node biopsy in those who have a good clinical response. And then in terms of what to do with node-negative patients that get neoadjuvant chemo, I think a sentinel lymph node biopsy, it's really in the gray zone right now. Almost done. Thanks for bearing with me. Last discussion is lymphedema. As we all know, this is a horrible disease. One of the things that just breaks my heart literally is when I have patients come back to my clinic and they have a huge arm, and knowing that I caused that to them. Lymphedema is very poorly understood. A lot of times it'll start within the first 3 years, but I've seen it start 5, 10, 15, 20 years later. It's not only a very morbid condition, but also it adds an expense to the patient. I usually quote patients with complete axillary dissections. There's about a 20 to 25% risk of this. A lot of these patients will get radiation, and that bumps their risk up to about 40 to 50%. Typically after a sentinel lymph node biopsy, that risk is around 3 to 5%. Have I seen it? Yes. Unfortunately, I have 1 or 2 patients that had a sentinel node and they have lymphedema, but it is rare. Obviously, the biggest risk factor for it is doing an axillary node dissection. Also, obesity, any infection of that arm, radiation is another huge one, and then age. Treatment has always been compression, manual lymphatic drainage, exercise, and skin care. We're still promoting this. Recently, there has been 2 competing companies, Lymphopress and FlexiTouch, and we've had really good success with this. These are sequential pumps that patients wear at home. They wear them for about an hour a day. This is something they can do on their own, and they put this vest on, and compression starts here, and then it works its way up the arm into the chest. And like I said, we've had really good success. Patients seem to enjoy it. I haven't really had any complaints about it at all. And fortunately, insurance companies have been pretty good about paying for this thus far. Precautions. This has been a kind of a big headache for me, trying to teach the new guidelines on lymphedema precautions. Numerous studies here. I listed just 3 on the side. Basically, patients who have sentinel lymph node biopsies, where you take less than 5 lymph nodes, there's no precautions, there's no contraindications. Patients who have complete axillary lymph node dissections, surprisingly, current literature supports no precautions with them either. They can get blood pressures, they can get IVs, they can get labs, they can exercise, they can go on an airplane. Now, good luck trying to tell a nurse who went to school in 1970 that that's true. They will fight you tooth and nail about it. So I kind of pick my battles. So what I'm telling patients and nurses now is ideally, if you can use the other arm, great. In situations where you need to use an arm that had a complete axillary dissection, if the arm is asymptomatic, no swelling, it is okay to do those things intermittently. And also it's really important about patient education too. Fortunately here we have a really good lymphedema team. We have physical therapists who have extra training in lymphedema. So in patients where I do an axillary lymph node dissection, I will have the physical therapist see them in the hospital post-op day 1 or 2. They take measurements of the arm, they teach them exercises for home, they teach them about skin care, and then I have them follow up with them after surgery. And we keep a really close eye on that arm. Also at Sanford, we're looking at the L-Dex system. Fargo is currently trialing this right now for the enterprise. This is basically a bioimpedance spectroscopy device that kind of measures resistance in the tissues. Basically, you hook up a probe to the arm and to the leg, and you look for resistance in that tissue. You get a value, normal range, abnormal range. Our protocol is we do a baseline prior to surgery, and then they do it every 3 months. You start getting values out of that normal range. That can be an early sign of lymphedema, and then we have them see a physical therapist. Talked a little bit about this last year. It's gaining more acceptance. I personally have not done this. It's called reverse axillary mapping. Technetium is injected in the breast. Blue dye is injected into the arm. When you do your sentinel lymph node biopsy, you want to be careful looking for that blue dye. Try to avoid those channels and lymph nodes if you can. There's also lymph node transplant. I did my fellowship at University of Iowa. They do this here. It's typically reserved for really symptomatic patients, really swollen arms, failed all other therapies. And what they'll do is they'll transplant some lymph nodes, typically from the groin, place them up in the axilla. On all the studies I read, they basically do that reverse mapping too. They'll do blue dye in the leg, they'll do technetium in the belly, they'll try to avoid the blue dye because you don't want to trade lymphedema of the arm for lymphedema. That's it. Any questions? Dr. Dan.
Thanks. So you had a nice slide on your pragmatic approach to what you do. One of the things I was wondering is, would you tell the residents to do frozen section on your sentinels or only permanent?
The difference is, are you doing a lumpectomy or mastectomy? So with lumpectomy patients, clinically node negative, small tumors, I no longer do frozen sections. In mastectomy patients, I still do frozen sections routinely. And that's where that decision making comes in. If a node, only have one node positive, the other 2, 3, 4 are clean, probably not going to do an axillary section. If 2 or 3 or 4 lymph nodes are involved, I'm probably going to do it.
Does your algorithm change whether they are neo-adjuvant or not?
Yes, so in neo-adjuvant, I still do a sentinel node in a mastectomy patient. And again, if that comes back negative, no further axillary section. If even one lymph node is positive in a neo-adjuvant patient, I will do an axillary section.
And you do frozens for that scenario too.
Exactly.
With the more aggressive use of radiation in your mastectomy patients, are you seeing your lymphedema rates rise, and or is that, I guess, taken into account?
I agree with the statistics there. I do think it almost doubles the rates of lymphedema. So in my axillary section patients that get radiation, I'm very hypervigilant about their arm and looking for signs of lymphedema. Yes, absolutely, it increases it.
For the neoadjuvant group who would have complete clinical response, how would you approach the breast? Would you offer them mastectomy or lumpectomy? Do you pre-mark the tumor site? How do you?
That's a good question. So obviously when we do biopsies of any breast malignancy, they clip that. And then, to me, a lumpectomy boils down to tumor size to breast size. Surprisingly, lumpectomy has nothing to do with the biology of the cancer. So I've had situations where women come to me with a large malignancy. They have a great response to chemotherapy. That area has been clipped. If they now want a lumpectomy, that is fine. We do offer a lumpectomy.
Just for the clip, or?
Yep, so and that's a great question, Hassan, because there's some different thoughts there. Do you take as much tissue that you originally would, or you just take, a couple centimeters around the clip? kind of different schools of thoughts on that. I tend to just take, a couple centimeters around the clip, look at final path. If it just shows fibrotic tissue, scar tissue, no active malignancy, then there's no point in taking the rest of that tissue.
Lymph node, if you are looking for a response and you took it out and you x-rayed it in your room and you don't have the clipped lymph node, how many lymph nodes will you take to try to make sure to get the clip?
That's a great question. So if I did a sentinel lymph node biopsy, I took out 3 or 4 nodes, we x-rayed them all, I did not see the clip, I would proceed to an axillary dissection. Because it's really important to get that clip node. Because that's a main indicator.
Jesse, in those neoadjuvant patients where you said you should get 3 nodes on sentinel node, what if say you use blue dye and technetium and one node is blue and it's hot, and then you take it and the rest of the axilla is cold and there's no blue?
That's I was hoping nobody would ask that. That's one of the concerns that trial alluded to. And in that situation, if you can't find any other blue dye, you cannot find any other tracer, I do rely heavily on palpation. And if there's any slightly enlarged lymph nodes, any indurated lymph nodes, I will remove those. That's not ideal, but it's better than nothing. And then I really rely on that x-ray. If that one node has the clip, you got the node you wanted, I personally would feel okay in not taking any other lymph nodes. If that one node you take out does not have the clip, can't find anything else, unfortunately I would proceed to an axillary dissection.
So that would mean that the sentinel node was truly negative,
right?
And it kind of debunks the concept of the sentinel node.
Fortunately, that situation's rare.
Yeah.
Right. And I don't know if Dr. Daneman agrees or not. I think I saw some studies where they're saying that true sentinel node is accurate about 94% of the time, something like that.
I was quote 96.
96%? Yeah.
Jesse, you started by saying that the topic is not sexy, and it's not, but what you do is keep women alive so that their families can be with them.
No, I didn't mean any disrespect with that comment. I love what I do. The main reason I chose this is because of the patients and their families. And nothing against doing gallbladders and hernias, but you see them a couple times and then you're done. And that's what I really love about my job, is getting to know the patients, their families, developing relationships with them, and leading them through a very difficult time, very scary time. And 95% of them do very well. It's very rewarding. So selfishly, it's a very rewarding field.
Technically, it's challenging. It requires a lot of scientific thought.
Yep.
You have to stay ahead of the literature.
Yep.
And when people will disparagingly say, well, you can just, technically you're not very gifted, go be a breast surgeon, that's insulting.
Yep.
I think what you do is incredibly important.
Well, I appreciate that. And I think that's a good reminder to residents too. A lot of my cases are junior level cases, and that's just fine. Axe dissections can be difficult. Doing a nipple sparing mastectomy through an incision that big is difficult. But you're right, Dr. Jones. I mean, the hardest part with breast cancer is decision making. What to do, when to do it, how to do it. It requires an entire coordination with medical oncology, radiation, plastic surgery. I mean, there's so much that goes into it nowadays, and that's the hard part. That's the hard part. Thank you.
Thank you.